Hey, good morning, everyone. So again, I'm Stefan Bork. I'm Associate Professor, Department of Anesthesiology and Pain Medicine, and it's my pleasure to introduce our next speaker, Dr. Nicholas Conradi. So Dr. Conradi holds a BSc in Biological Science and Human Geography from the University of Alberta, an MPH from King's College London, University of London, and an MD from the University of Limerick. He is also the co-founder of the World Interdisciplinary Forum for Healthcare. He's currently a pediatric resident and completing his PhD in the Department of Pediatrics here at the University of Alberta. His work focuses on developing the technique to provide off-grid oxygen to remote and rural areas, which I believe is what he's going to be talking to us today. So the title of his talk is Solar-Powered Oxygen Delivery in Low-Resource Settings. Dr. Conradi?
Hi there, everyone. Are you able to see my slides?
Yes, yeah.
Wonderful. Well, first and foremost, a big thank you to the organizers for inviting me to speak today at the Global Health Fair, and a big thank you to the previous presenters as well. Very interesting. Let's share my video. Sorry. Is everyone able to see? My name is Dr. Nick Conradi. As was mentioned, I'm a pediatrics resident at the University of Alberta and have the pleasure of working with Dr. Michael Hawkes, who is a professor and a physician at the Stollery Children's Hospital, an infectious disease specialist, but also does an incredible amount of work in the field of global health as it relates to the design and implementation of a solar-powered oxygen delivery system, which will be the focus of my presentation today. And over the past number of years, I've been also pursuing a PhD with alongside Dr. Hawkes as my supervisor, looking into the mortality benefit of these oxygen systems as they're rolled out on the ground that I'll get into in a minute. Now, let me just make sure that there we are. So over the course of the presentation, I'd like to be able to talk about the burden of pneumonia and hypoxemia in low resource settings around the world, to overview our solar oxygen system, how it operates and its implementations around the world and the outcomes of those implementations, and to finally discuss the next steps and plans for expansion down the road. But as with many of these medical presentations, we often begin with a case, and to kind of orient us. And this is a real case that occurred in the early days of our implementation. So a 6-month-old boy is brought into hospital by his mother. She says he has been sick for the past number of days and has been getting worse. He has a fever, a cough, and a significant work of breathing. So it's breathing fast, and you can see the muscles of respiration being used significantly. She also states that hasn't been feeding very well and is worried that he's getting dehydrated. You measure the oxygen saturation, or the percentage of oxygen in the blood, and it's found to be 82%. And the question is, what do you do? And what we know is that what you do is very dependent on, as a colleague of mine likes to say, like real estate, it's dependent on location, location, location. So on the left side of the screen, you'll see a scene that's very typical of emergency departments across Canada and the developed world, where you have a hospital bed, you have all of the equipment around the room to both maintain your personal protective equipment, to be able to ensure you have medications available to help resuscitate children that might either be dehydrated, might require antibiotics. And we have oxygen that's available, oftentimes piped right out of the wall built into the hospital and able to be provided directly to the child. And on the right side of the screen, we see one of the health centers that we've been working with over the past number of years, where it's a very different context, where we see a number of sick children clustered into a single room. The availability of that equipment that I was mentioning is sparse, and there's the availability of electricity in these instances is sparse as well, that I'll get into in just a moment. So what you do is dependent on where you are. When it comes to mortality from pneumonia, which is a leading cause of death amongst children under the age of 5, we see that it's clustered in low and middle income countries, particularly in Central and Sub-Saharan Africa. You see some of the darker blue countries here, including Chad, the Central African Republic, Southern Sudan, the Democratic Republic of the Congo, and Nigeria, all of whom have a high burden of deaths from pneumonia amongst children under the age of 5. And what we see is that the typical management of pneumonia, which is an infection of the lungs caused by typically in these instances a bacteria, leading to inflammation and the difficulty of oxygen being able to enter the lungs and enter the bloodstream. That over 920,000 children under the age of 5 die every year from pneumonia. Only 4% of these children have access to life-saving oxygen. And what we know is that when children have the ability to access that oxygen, previous literature suggested that reliable access can reduce mortality by up to 35%, so a significant margin. As our group has conducted research on the ground in most notably Uganda, we found that that only about 18% of pediatric wards that were included in our survey had access to functional oxygen delivery. Keyword there being functional. Some might have access to oxygen cylinders that I'll tell you about in a minute, or concentrators, but they may not be functional. 72% of sites experienced frequent power outages. 92% of the nurses that were surveyed in our studies felt that children who required oxygen did not always receive it. And 100% of nurses surveyed felt that they needed additional training in the administration of oxygen. And none of the nurses surveyed identified that they had clinical protocols for the use of oxygen. So highlighting a quite significant gap in the availability of oxygen in these settings, in areas that have a particularly high burden of pneumonia. So how is oxygen delivered currently? Really, it falls into two main categories. What you see here is an oxygen cylinder where oxygen is compressed into a pressurized metal cylinder. And this is pretty much the standard in low resource settings. And the advantage is that it doesn't require a power grid to operate. You attach the tubing from the patient's mask directly into the cylinder and are able to deliver oxygen that way. The challenge comes when it comes to the transportation and maintenance of these cylinders. What we find is that often these cylinders are filled in a centralized location, often the capital city of whatever country they're in, and they have to be transported to far away and often rural and remote settings, complicated by difficult supply chain management, where the cylinders will bang around and often crack and leak and become inefficient that way. And so there are some logistical constraints in terms of the use of oxygen cylinders. The second modality is what's called a grid-based oxygen concentrator, where we have a device that is present within the hospital ward that is able to extract oxygen directly from the ambient air and be able to provide it directly to the patient. The unfortunate thing, as I had mentioned on a previous slide, is that the majority of sites report frequent power outages and thusly render the system non-functional during the periods when there are power outages, thusly not being able to provide the child oxygen. So from a reliability standpoint, there are some constraints as it relates to the oxygen concentrators. So what we've seen over the past number of years through this COVID-19 pandemic is that oxygen has been a critical resource in the management of these respiratory illnesses, and that its availability has been highlighted as being a key issue for the world. And so we've been in need of new and innovative solutions to be able to bridge that gap. And Dr. Hawkes designed a system that is about as simple as it gets. It's a solar panel attached to the roof of a health center that is able to collect solar energy and uses the electricity generated from the solar panel to power a bank of batteries that are installed in the health facility itself. And that stored electricity is then able to be used to power one of those bedside oxygen concentrators that extracts oxygen directly from the ambient air and delivers it for up to 2 patients at a time. So a simple system of a solar panel powering a bank of batteries, powering an oxygen concentrator to deliver oxygen. And what we see is this is a typical example of what the oxygen system looks like on the ground in Uganda. On the left, you have the solar panels. A second from the left, the bank of batteries. Second on the right, the actual oxygen concentrator. And then on the far right, an adorable kiddo with the oxygen being piped in from the oxygen concentrator itself. So our group has been very intentional about being exhaustive in our assessment of the oxygen the solar oxygen system. And we've been publishing the merits of the system throughout its implementation, starting with an initial proof of concept that's able to show that yes, indeed, the system can concentrate oxygen and can deliver oxygen to children with hypoxemia or low oxygen saturations in the blood in low and middle income countries. And that the oxygen system is non-inferior to current standards of care, i.e. the cylinder oxygen system, and that critically it's cost effective. And then we have also, as I'll get to in the next few slides, been working on assessing the mortality benefit of implementing the solar oxygen systems on the ground, and to what degree can it actually help to reduce the burden of mortality from pneumonia and respiratory illnesses. And then more recently, we've been paying particular attention to the costs of the system and whether or not they're a cost-effective solution in treating hypoxemic illness, which it is, and I'll get into it in a second. And also, we've published some of our implementations in some of the hardest to reach areas around the world. We see from this publication on the bottom that we've recently implemented in collaboration with the World Health Organization in Somalia. So I'll delve a bit into our major stepped wedge cluster randomized control trial, which is a big fancy word for a randomized control trial that looks into the mortality benefit of the solar oxygen systems. So our study aimed to compare the 48-hour mortality amongst children aged less than 5, admitted with hypoxemia or a oxygen saturation of less than 90%, before and after the implementation of the solar oxygen systems in 20 hospitals across Uganda, adjusting for the confounding effects of time and site. And what we can see here in the map that you're looking at is that we had good geographical coverage with sites being recruited in the eastern region, northern region, western, and central regions of Uganda. The study followed what's called a step wedge cluster randomized control trial, which is a very modern and practical method of being able to implement these large-scale infrastructure type projects that helps us to maintain the scientific principles of randomization and things. Not to get too much into the statistics behind it, but in a nutshell, over the course of 2 years, we had, on a month-to-month basis, randomly selected sites across the country where we would implement the next solar oxygen system in. At the beginning of the trial, all sites started the trial with no solar oxygen systems installed in them, and then on a month-to-month basis, we would install the systems, and by the end of the trial, all sites had access to solar powered oxygen delivery. And the way the study worked is a child who was admitted to hospital with hypoxemia. The parents or the legal guardians were approached to provide consent, and if granted, the patient would be admitted to the ward that would or would not have access to the solar oxygen system, depending on the schedule of implementation that I showed in the previous slide. Patients then would have access to standard of care, and we ensured that there weren't any stockouts or of essential medications. And basic demographic and clinical data was collected throughout the study. And then ultimately, at the very end, we measured the survival at or after 48 hours at discharge, and then and whether or not there were any transfers to another facility. We're very happy to report the results of the trial that did indeed highlight a decrease in the mortality from about 5% of children in the pre-solar oxygen period down to 2.9%, which represents a relative reduction of about 50%. And that's with regards to 48-hour mortality, but we also saw a similar reduction in overall mortality. So not just at the 48-hour mark, but also beyond that. So what that highlights to us is that that solar oxygen, the implementation of solar oxygen, was indeed associated with a lower mortality after its implementation. I'll draw your attention to some of the other outcomes that we have here under our secondary outcomes, where in the pre-solar oxygen period, about 50% of sites had access to oxygen in some form or another, whether it's the cylinder oxygen or a grid-based oxygen concentrator. And at the very end of the time period, 99% of sites had access to oxygen. We were also encouraged to see that there was a reduced frequency of transfers to other healthcare facilities, which is often associated with incredible costs and logistical struggles from the perspective of the family, and that more children were discharged without disability in the post-oxygen period. So overall, we're able to conclude that solar oxygen is a life-saving and cost-effective intervention for the treatment of children with hypoxemia in resource-limited hospitals. And it addresses a critical gap in the access to oxygen across low and middle-income countries, and if taken to scale, has the potential to reduce preventable childhood pneumonia deaths. And then, as I had mentioned earlier, in addition to the assessment of mortality, our team has also been working to identify the cost effectiveness of the solar oxygen system. And we see, as compared to other notable public health interventions, that the solar oxygen system is incredibly cost effective. Works out to about $20 per disability adjusted life year saved, or $26 per patient treated, or $542 per life saved. And then what you see in the graph in the lower right side of the screen are some of the other conventional public health interventions that have been known to reduce mortality amongst children under the age of 5. Most notably, the pneumococcal conjugate vaccine, which was found to have a cost effectiveness of about $100 per disability adjusted life year saved. And so our $20, and we know that vaccines are an incredible method of being able to reduce mortality amongst children. So the fact that our system was $20 per disability adjusted life year saved is a pretty strong message. And here we have some sensitivity analysis, which just helps us to identify what it is, what factors affect the cost effectiveness, the cost effectiveness of the solar oxygen systems. And most notably, it's based off of the number of cases of pneumonia. So the systems are particularly cost effective in high burden areas that struggle quite significantly with burden of pneumonia. Finally, here we have our next steps. So we have currently implemented in the Democratic Republic of the Congo, in Uganda, Tanzania, and Somalia, and we have ongoing work to be able to identify additional partners in other jurisdictions such as South Sudan, Kenya, and others. We're also working with our partners on the ground that have supported our research endeavors to help identify other modalities that can help to deliver oxygen and help to lower the cost of the systems as it relates to the upfront costs of a hospital purchasing the system, which is about $10,000 US. So a significant upfront cost for a local hospital. So we're trying to find ways to be able to reduce that upfront cost and to help hospitals recover those costs. And then lastly, once we have now that we have the mortality benefit, the cost effectiveness, and soon some of that market data collected, we hope to be able to implement the system more broadly amongst low and middle income countries. So I started the case off with the lecture with a case, and that was the case of Benson, a little 6-month-old boy with pneumonia who was brought by his worried mother to a health center in Kambuga, Western Uganda. And there was no oxygen available at the health center, but the nurse had heard of a solar oxygen trial going on at a nearby hospital. So Benson was transported by motorbike and treated with solar oxygen for 5 days. And he's made a full recovery and is doing very well many years later. And this is Benson and his father, one of our implementation specialists. So a big thank you to everyone, and I'd be very happy to answer any questions.